everyone. Welcome back, and thanks for joining
Welcome
us
back
again.
to you, because you weren't here last week.
I wasn't. I'm so sorry I missed last week. Really excited. I got to watch live from my home, and I know we had Bob on with Jeff talking about health joy. Well, we're back today with our third episode of Tech Talk Tuesdays. I'm Nicole Tedford, here with Jeff Smith, and really excited about today's topic, you guys. We're going to be talking about how technology has enabled and changed the way care is actually delivered. Especially, over the past several months when we were shut down, really had to shift, really had to pivot how care was delivered. We're excited today to be joined by Chad Ashcraft, Chief Revenue Officer at Our Health. And before we actually jump into the topic, Chad, talk to us a little bit about Our Health and Marathon Health and your role and what they do.
Sure. Thanks for having me. First of all, appreciate the opportunity to be here. So Our Health has been around for over 10 years. We recently merged with Marathon Health, another vendor in this space, and now we're one of the largest and leading national providers of independent primary care and population health solutions for employers directly. So it's a little bit different model than your traditional health system or health services, where it's a capitated, really value-based care model that we do with employers directly, focused on, not transactional in nature, but relationships. Really believe in the value of an independent primary care provider and an extended care team, being able to really drive the outcomes and overall health and wellness for an employee population, and then drive those downstream employer savings. And so we've had the opportunity to partner with Haran in the past. We launched Cincinnati, which is our near site MyClinic network that we have there, where we build out a network of independent primary care centers with the care teams and medications and lab services, the whole scope of services. We launched Indianapolis first, Charlotte, North Carolina, launched Cincinnati. We have 4 centers in that area that we launched in 2019, and then we're getting ready to launch Columbus, Ohio here in January 2021. So
that's awesome.
Mm-hmm.
That's awesome. Well, I'll tell you what, Chad, you have a great story to tell, and I know we've talked in the past, and we've had numerous discussions. I know you work with Dominic quite a bit too, and really kind of cementing this relationship with Haran. So first of all, I want to thank you for that, on top of the numerous things we're doing for the community here in Cincinnati, and what you guys have done in Indianapolis and Charlotte as well, and one into Columbus. Not to mention Wilmington. That was huge hit, and that was huge for what the footprint we wanted for Haran up in Wilmington. But today's topic, I really want to talk to you about virtual health and virtual healthcare.
Mm-hmm.
During the pandemic, we saw a huge slide with people who are going to see their primary care physicians versus going on to a virtual health platform. And you know that as well as anybody else working with a lot of your clients too. You see billboards, you see urgent cares, you see all this stuff that you can join a virtual health standalone, if you will, throughout the state of Ohio and our region, of what we're trying to kind of accomplish. Virtual options are there. I think what you guys kind of offer is a little bit different than the normal standalone. But I think a lot of people think it's a little confusing. And I know from probably some of the calls you've received, they're like, where do we go for virtual care, whether it's through our carrier or payer or whatever the situation may be. We're a little confused on the virtual health aspect of things. And during the pandemic especially, people really had no idea what to do. So if you could describe a little bit the options and the differentials of what Our Health brings versus one of these standalone doctor on call, if you will, minute clinic, on all these different things that we have going on right now. What does Our Health and MyClinic do a little bit different than the others?
Yeah, it's a common question too, and a good one. So I've always found it helpful to kind of frame the different solutions in the context of capabilities. And by capabilities, I mean really the differences in how those different settings are able to diagnose, treat, and manage different issues and conditions.
Sure.
So I'll kind of start on one end of the spectrum, which is sort of the in-office primary care setting. So if you're in an office and you can speak with a primary care provider or extended care team, they have a medical history of you. They're able to diagnose and treat, really 1,500 is about the number, 1,500 or more different types of conditions or issues to diagnose, treat, and then manage. So that's kind of the one end of the spectrum. And you kind of jump to the other end of the spectrum, right? And this is where telehealth and the 200 plus vendors like a Teladoc come into play, where they have physicians who are mostly, moonlighting in some cases, providing their expertise to really convenient access care, acute in nature, trying to keep people out of emergency rooms and really urgent care settings. Because of the fact that they don't have the medical health history with the patient, they don't have a complete full view of the history and what they've been doing in the medical system, because they can't really do follow-ups and communicate with the patient post those calls and orders and things like that for labs, referrals, et cetera. Their scope of really practice in those settings are about 30 different conditions. So we got 30 versus 1,500,
right.
Okay? And they kind of walk that kind of spectrum up there. You got retail clinics, right? So this to be your little clinic or minute clinic type setting, some limited urgent care. And it depends on the staffing model a bit, but they're able to maybe diagnose and treat about 50 to 100 different conditions or issues that a patient might have, right? So you got 30 on telehealth, 50 in a retail clinic, and you got 1,500 kind of the full scope of practice up there in office. And so what we kind of term as kind of virtual primary care, right? This is where you're able to have a virtual appointment with your provider or your care team, people who know who you are, who have a history with you, right? And so this is where you're, as a patient, really weaving in and out of face-to-face in person with virtual to be able to have that convenient access, but also to be able to, have that context where they share that, them, so it's familiar, right? So in that setting for a virtual primary care provider who you've already established care with, remember 1,500 was the in-office. It's about 1,350 different issues they can treat. So almost 90% of the issues can be at least treated or triaged or checked in with respect to a virtual care appointment with that provider who knows you, right, and has established that care.
Sure.
And so that's a big difference, right? And I think it starts to hopefully underscore the difference of the scope there, and what we believe in the Our Health world, and combined with Marathon Health, is that the combination of in person and having the ability to be able to see that care team in person, and then also leverage the virtual primary care aspect, is really the combination of where you get the most value for your spend, but also can drive the biggest outcomes and downstream impact on the health employer spend.
Yeah, and I think from Nicole and my perspective, and I think you made a great point there, it's the value piece. It's the value proposition, what you bring to the table. You can jump on anything you want as far as virtual health goes or Teladoc goes, but I think that's the most important piece. And I think you're talking huge numbers, a huge differential in numbers right there.
Mm-hmm.
Yeah.
And I think that's very key. And I appreciate you sharing that with us as well.
Yeah, so Chad, Jeff, just to kind of boil down some of these points, virtual care is going to be here for a while. It's definitely not going away. I think we saw this great shift.
Oh, yeah.
And it's been around. Again, this isn't new. Virtual care has always been an option. Teladoc's been around for a while, but now having that access through primary care and having, the primary care physicians really get into this world in a different way has been really cool. So one, virtual care definitely here to stay. Second wrap-up piece, I think really are the convenience versus the cost. And I know, one quick question, Chad, on cost is around, some of these charge, a small per employee per month fee to employers, while others are going to charge, the actual cost of a doctor's visit. Can you talk to us a little bit about the differences between those two?
Sure. So in a traditional fee-for-service model, I think a lot of your audience is familiar with that, as you are, where you're paying for what you consume, and it's billed back through insurance, and if it's preventive, it goes to the employer, or if you're self-funded, and a lot of that's passed through the patient now in a high-deductible health plan. But those traditional office visits are anywhere from on average $145, $150, and they could be up or down, right, to be seen in person. The telehealth costs that we've seen that are pretty familiar in the market, usually they're charging pretty low per employee per month fee, right? A couple dollars, $1 to $2, and then they're going to charge anywhere from $49 to $79 for a visit fee that the patient would pay for that access. Again, that's only for those 30 really different simple issues that they can safely diagnose and treat on those phone calls. And the utilization rates for those, or usage rates for those, when you look at it, defined by really having 2 or more different encounters in a year. That's about less than 5%, 3 to 5% is usually what you're seeing. So yeah, it's a lower fee, and in some cases it's comparable with what you'd see in the open market for a fee-for-service setting, but the utilization is very low, and you kind of get what you pay for, right? So low capability, kind of leads to low utilization, and the other piece of that is that they're not impacting really the highest cost claimants. If you're only seeing those 3 different types, that's pink eye and ear infections and things aren't the things that are leading to the cost of an employer's health plan, right? And so by contrast, when you look at from a cost standpoint, and a model like ours, and kind of advanced primary care, when you have access to health coaches and CDEs and behavioral health specialists and all the lab services, it's unlimited kind of free visits for those employees and their households for a per employee per month fee. So it's a capitated annual rate. It is definitely higher, more expensive per individual than the telehealth, but at the same time, you're talking about getting those 1,500 types of conditions we can treat, really complex care. We're able to navigate downstream referrals locally with the physicians and providers in the local market, looking for that balance of low cost, high quality types of providers, and really have a much bigger impact, which is where the high cost claimants are, and those ticking time bombs in those employers' health plans are that we really try to go after and get to that are high risk.
Right. Yeah, Chad. So virtual delivery shouldn't mean you're sacrificing on health. In short. Right.
That's right.
We're up against the clock, and I know we want to be time sensitive to everybody who's watching this real quick. A couple quick questions for you real quick. Utilization during the pandemic, did you still receive really good outcomes? 2 minutes or less, A, that's the first question. The B, the second question, I know that the pharmacy is a really big time player within the our health model. Explain to me how you did that through a pandemic where people could go to the
Yeah, that's a great question. So March 1st of this year, we were about 90% in person and about 10% virtual.
Wow.
April 1st, we went to 90% virtual, 10% in person. That's just letting the patients kind of engage with us and choose. And so for really that 3-month span of April, May, June timeframe, we were about 90% virtual, 10%. So we pivoted very quickly. We had already started to roll out virtual capabilities anyway. And so our NPS scores from a quality standpoint, were 95, so they actually were a touch higher than they were previously, which is a great NPS if you're familiar with that kind of model. And our patient satisfaction rates were about 85%. So the patient's perception, I think the scoring that we had would indicate that there's still really high quality and obviously delivering a way for them to engage with us that they wanted to see. We did something, to your point about the medications. One thing we did in April as well is we kind of took our providers while there was that lull where everyone was adjusting to pandemic life, right? And we had them actually make a lot of these proactive outreach calls to high-risk patients. A lot of those were focused on people that had multiple medications, right? And so we have a medication dispensing in all of our health centers, and then we have a home delivery system as well that we leverage as a partnership. And so we did these virtual hugs, as they called them, right? And these were virtual hugs where our providers reached out, our care teams reached out. We reached almost 250,000 people in those 3 months to be able to reach out. And a lot of those were calls about trying to say, do you have everything you need? We're still here, even though you can't leave your house. We can send medications home to refill, so you don't need to come in and pick those up. And basically, that was a big piece of what those virtual hugs were all about. In addition to just checking on how they were doing and providing a good touch point to let them know we were thinking about them, which I don't think anyone else in the healthcare system locally or nationally was really focused on doing that.
Right. Yeah. Right. Hospital systems aren't doing a whole lot of that either. So, hey, I know we're kind of up against the clock right now, Chad. I can't thank you enough. I can't thank you enough for the partnership with Haran. It has been a tremendous amount, not just to our organization, but to numerous people in our community that have really benefited from what you bring to the table and what your whole group brings to the table. So I want to thank you for that. Love to have you back on again. We're going to try to hopefully continue these Tech Talk Tuesdays into the future. But for being one of our first folks on, Chad, I can't thank you enough. Anything you have on your side?
No, thanks, Chad, again. And that's it for today. Join us next week on Tech Talk Tuesdays at 2 o'clock. We'll be talking about benefit administration in a virtual world.
Yeah. Thanks, Chad.
Thanks, everyone. Bye.